Earlier today I spoke with a guy named Norman Levy, who is an 84-year-old psychiatrist, still working in Los Angeles. But I knew him when I was a medical student and resident, and he was the one who coined, as best I can figure it out, the term psychonephrology. And for about a dozen years had a group of people from around the world who would convene every 2 years to talk about various aspects of it, things that they were studying. And it's in that tradition. He had a certain elegance to how he managed to pull it off. I see that tradition being followed by Gav, and I see that this is a group that will continue in that direction. It's wonderful for me to be here. So let me say that I don't think I have all the answers. I've done a number of things and I can speak to them, some more successful than others. I've put up not only my email address, but I have a long-term collaboration with a guy named Michael Germain, who's a nephrologist. And so don't hesitate to send queries to Mike, who likes nothing more than to provide references and answers to such things. Now what I wanted to start with is, and we're going to cover a bunch of different areas, but one I wanted to bring up is sort of a homegrown product. Sarah Davison, she put together a meeting that was held in Mexico City in 2013 that you may or may not have heard about, but I think has great relevance to anyone who is interested in this subject. I had a small part in putting it together, and this was a conference about really renal palliative care, or the other term that people use is supportive care. But what made it different was that Sarah was interested in bringing together nephrologists from all around the world. And so it was not just first world countries who were present in Mexico City, but it was nephrologists who were attempting to provide care in Africa, in Latin America, in Asia. And so what was very evident, and we knew it would be right from the start, is that the kind of nephrology that we know in first world countries whole different thing in other countries with different variables that often have considerably more importance than we could ever imagine. And so I would urge you, this is kind of thing, limited resources. This is challenges to Mexico to provide supportive care to their patients, identifying CKD, dealing with very limited resources, dealing with very limited palliative care resources, cultural issues that would interplay, religious attitudes. And I would say we're going to come to this at the very end of my talk as well, because when you think about providing sensible end-of-life care to a renal population, you can't get very far from attending to the cultural, the social, the family, the society's attitudes about these things, and the tensions that may be there between you, the nephrologist or psychiatrist or social worker, and your patients. There's been an executive summary that's been written up, and this is the reference for it, and there will be subsequent papers that are going to come out of this conference. But it was unique, and I think it's really incredibly important. And if you think of a camera, just changing the focus and expanding out, when you start thinking about this with the whole world as being what you're looking at, it becomes quite different. So supportive care, or palliative care as I knew it, what you'll see is that we think of it as a patient-centered versus a disease-centered approach. There's much more attention to people's symptoms and what is actually distressing to them that they want cared for. And the whole notion of goals of care has become exceedingly important. And it's a big shift. the shift from this thing that they call patient-centered care. I was telling Gav, I don't really know what it means, but as best that I know what it means, it's asking people what they want, what's important to them, and then seeing if you can bend your medical care around helping them to achieve that. Families are a big part of that, of course. Now, the old palliative care paradigm was really one in which, if you will, we had ourselves curative therapies, and then there came a certain point where we kind of threw in the towel, and that became the point where the palliative care would come in. And it was really, what was then offered was relief of suffering, check you into a hospice, and then a person died. Many of the folk who are in palliative care nowadays resent, when people think of what they do in that light. Because what they would like to think of is that palliative and supportive care can begin right in the beginning. That if we're paying attention to symptoms, if we're paying attention to goals of care, then we're talking about right from the start when disease becomes evident and people get seen by medical folk, that, if you will, palliative care should show itself, becomes more important as things progress and the illness progresses. And then you still have the hospice, and then the added piece with hospice, which I really like, and I'll speak to that as one of the things that I'm proud that we tried doing with some of our renal clinics, and it's been picked up by a number of dialysis programs around the US. It has to do with bereavement and bereavement care for families and patients.
Lou, just a quick one.
Yeah.
One of the tensions within, I'd say, Toronto, I don't know, more widely, is that, when we intersect with the palliative care services, it's very much an oncology perspective. So they will say, can you guarantee your patient will die in 6 months?
Yes.
Otherwise they can't come into, otherwise they can't come into our program.
Right.
And it's really that oncology paradigm.
Yep.
And a lot of times you can't, or sometimes you will keep the patients on dialysis, although they're palliative, quote unquote.
Right, right.
It's almost, we talk a lot about speaking two languages between patients who are coping and the medical world. Mm-hmm. I think there's also almost like two languages between the oncology palliative care perspective and nephrology.
It's not all that separate and different. As you mentioned, you think of renal dialysis as being a palliative care treatment that you would continue even if a person met that 6-month criteria. And similarly, there's chemotherapy that's done that that's recognized to be palliative chemotherapy that is likewise done. But there is a real tension that you're pointing out that does exist. There are some ways in which I know that Mike Germain and I have, if you will, followed the oncology type of palliative medicine way of looking at things, because our belief is that, in fact, you can come up with good prognostic indicators that can answer that question, that yes, this patient is likely to die within the next 6 months. I don't sort of feel as if oncology and what they've sort of done is all that different, other than they've done a better job of it than us, and particularly when it comes to making use of hospice. And particularly when it comes to making use of sensible financial things. But yeah, we have a problem. We can't get people who actively want hospice services to continue to get dialysis in most cases in the United States. And that's a problem. There's something that's wrong about that. Let me just sort of chug along a little bit, if I may. Why the dialysis unit? Well, if you ask them, it is what patients and families do want. Some of them, in fact, want a good death. But they all want symptom control and a better job of it than has been traditionally done. And there are studies that suggest that the dialysis patients have as much or more severe symptoms than patients with the terminal cancers do. There is a limited life expectancy. I mean, by the time, somebody has had kidney failure and we walk into a dialysis clinic and take a look at the population in there on day one, come back in a year, and 1 out of 5 of those patients will have died. I mean, they are dealing with horrific mortality rates. It is not to say that we aren't keeping people alive 10, 15, 20 plus years, but it is to say if you look at the whole population that we're dialyzing, that the mortality is, certainly the equal to many of the terrible cancers. Some of the barriers for, oncology was indeed the place that grabbed hold of palliative medicine, and if you look at the Academy of Hospice and Palliative Medicine, it is the oncologists, it is the geriatricians who are really the bulwark of it. Nephrologists are rare and few to be present and attracted to this. And the question becomes why? Why not if we have patients who are dying at similar rates? Why not if we have people who are suffering with various symptoms? And a piece of it is that the nephrologists are uncomfortable using prognostic indicators. And we do have some decent ones now, and we could have better ones. I'll go over a couple of them before we're done. They're uncomfortable having the discussions about advanced care planning. They worry that patients will feel a loss of hope if one engages in conversations like that. They fear that there may be accusations and that there may be medical legal consequences to bringing these things up. They worry that the discussion to talk about such subjects will take more time than they can afford. And in truth, I think this is a big, big barrier because the nephrologists that I know and work with are the hardest working people I've ever met. And they literally do not have time. And they take time out of their family life and every other source to carry out the work. They're all overworked. So, the idea of adding on something, and especially something that could turn into a longer subject, holds them back from doing it. They feel the patient has a right to receive dialysis and other aggressive care despite the risk-benefit. And they then, certainly in the States, there's concerns about, come sit down. There's a concern about loss of income. So in the study that I'll tell you about that we're doing, we have 2 nephrology groups that are participating in it. And the big question that one of them had for me is, are you going to be, God forbid, encouraging our patients to stop dialysis? They have been a private group, and that would cut directly into their income. Now, America is changing its way of funding things, and this fee-for-service model is beginning to go away. So that incentive, that issue will be less so, hopefully, in the future, but it still is in the present. All right, so there are some obvious solutions, if you will, some ways to overcome the barriers and integrate renal supportive care. And they include, if the conversations were routine, if they were part and parcel of, say, the annual meeting that the nephrologist has with patients, or biannual meeting, and it was done with every patient. If, I don't know, we have the MOLST and the PULSE that's beginning to make its way. These are advanced care documents. These are order sets that physicians are now filling out on patients after having had conversations about their wishes. If that, again, becomes uniform, if the whole team, the dialysis team, and it's one of the things that always attracted me to nephrology, was this brilliant thing that to conduct dialysis, you needed a doc, but you needed a social worker, but you needed a nurse, but you needed tech, you needed a team to do it. If the whole team can get behind it, and that, by the way, is easier said than done because individual members may have very different opinions about these subjects. Because as I say, I'll get back to it, but this is stuff that ties into deeply held beliefs, and people can get very defensive and divisive about it. There are comprehensive programs out there that are doing it. This is really Mike Germain's take on things, but he feels in British Columbia, in the UK, in Australia, in Alberta, that they have a better handle in terms of offering comprehensive renal supportive care. And these are some of the outcomes that one would look and hope to have. There are some articles that are now appearing. There's in fact a fairly vigorous literature coming out that dialysis is not for everyone. I mean, we've had sort of an open season in the States and in Canada, but that has given us an opportunity to look at dialysis with, in some cases, the very elderly, and quite frankly, it doesn't offer a lot consistently. And so a part of a comprehensive renal supportive care program would be one in which there's the fourth option, which is to say conservative management, which is to say that dialysis, you can go into renal failure or approach renal failure, and that does not necessarily mean that you should be going into the rest of your life of dialysis treatment, but rather that it should be more weighted towards palliative care and other means of dealing with your renal failure. And as I said, if you open up that lens and look at the world, in Africa, in Latin America, in a number of the Asian countries, the only people who get dialysis are the very, very, very few who can afford to pay for it. And so what about all the rest of them? And then it becomes, we need to do some pretty damn good research and see what we can do about minimizing the suffering of those folk, prolonging their lives without dialysis. What we've been doing up until now with a lot of folk is we've been just sort of speaking of dialysis or any of the renal replacement therapies as being sort of the natural thing to do. We have found you have this problem, this is the solution to it. What I'll do is I'll tell you, I was going to shift at this point anyway to the current study that I've been able to do with some colleagues. There is a new funding organization that popped up in the States. This was an Obama initiative called the Patient-Centered Outcomes Research Institute, which is a mouthful, but it was meant to be a alternative, if you will, to NIH, an improvement to NIH. Obama money was provided, again, to do patient-centered research and to do something that I think is really kind of interesting, and I'll tell you about my own experience with it, which is to set up research studies in which patients would be, they'd have a seat at the table. They would be right there every inch of the way, working with the researchers as a member of the team, helping to define what the question is, helping to define what the methods are, helping to problem solve as problems came up. There are 5 renal studies that are being supported now. So there are 5 studies that I know of that right now are being funded by this institute. And when I'm talking funding, I'm talking about our study our project has 2 studies embedded in it that we are in the process of finishing off the second one. 3 years to carry it out, $2 million to support it. And what that $2 million has allowed us to do is to bring together 8 dialysis clinics from Massachusetts and 8 dialysis clinics from New Mexico down in the Southwest and see if we can get that conversation going, change that culture in the dialysis clinics, define what patients' goals of care are that they want. In particular, the kind of outcomes we're looking to see if we can change is hospice use. Can we, in fact, increase the percentage of our patients who are receiving hospice? Can we improve the quality of dying? Right now, dialysis patients, by and large, if you ask them, don't want to die in the hospital or in an institution. Where do they die? In a hospital or in an institution. Our goal, if you will, and really one of the goals of renal supportive care is to see if we can improve the quality of dying by a measure like that. We did the first study, which was a qualitative interview study in which we laid out for a group of patients and some family members what the intervention was that we had in mind, and we got input from them about it. And then the second study is an intervention study at these 16 clinics, and we'll compare the data, particularly the hospice usage, before the study began with once the intervention began. The innovations that we decided to use in our intervention, that some of which are working out better than others, we decided to use a prognostic indicator, prognostic instrument that Mike and I had worked on in another study, and it's posted online. And it allows you to plug in 5 different indices about a patient, then come up with a likelihood that the person is going to die within the next 6 months. Actually comes up with a number, and a number that has some clinical meaning as well. Because this was research, and we didn't have unlimited time and effort, and we were just trying to start something, what we decided was we would focus on the 25% of patients who had the, if you will, highest mortality rate among our patients. So we were looking for the most severely ill who we were going to give the intervention to. I should tell you now, having been doing this for the past year, if I had it to do over again, and if I was going to draw some conclusions already from the preliminary data we have, it's that was a mistake. That we should not have focused on the people who were closest to dying, but we should have, as I'd suggested kind of in an earlier slide, made this part of the routine and done it with all the patients. It should not have been restricted to just the ones who were the sickest. But that's what we did, and that's the data that we will collect. I still think the prognostic indicator, the use of it was a good idea, because it can inform the conversation that the nephrologist has with the patient and family. But that's another matter. The other thing that we did that was calculated and I think innovative had to do with social workers. And had to do with, I looked at the dialysis team and I thought, who amongst the members of the team should receive the most training and the opportunity to engage in this conversation with the patients and the families. I know full well that, again, from the first study and from other studies that have been done, if you ask patients who they want to have the conversation with, who do they say in the dialysis team? Who would they want to have a conversation about end-of-life issues? Doctor, okay. Ask the patient and they want to have the conversation with the doctor. Other aspects of this intervention that we came up with, which is that it would begin with a meeting in which we would try to get the patient and their family in a room with the social worker and the nephrologist. Now, what we hoped was that the nephrologist, who I know damn well is too busy to have more of these conversations, would be willing to empower the social worker on their behalf as the team member designate to take it on, to continue and then have a series of follow-up meetings with the individual. But indeed, get everybody in the room and you see stuff just like you're talking about. Yeah, it's complicated in that room, but it's going on and you'll never get on top of it. You'll never become aware of it unless you get everybody in the room to work on it. So that's what we did. I mean, we have given our social workers extensive training in communication and ethics and dealing with the various aspects that would be required in having such conversations. And we gave our physicians a little bit of training, but nowhere near the same amount. And we gave everybody a kind of script of sorts. We produced a video, which they were encouraged to watch and was part of the training. And again, that's what we have since launched. I will tell you, one of the interesting things that's come out, you bring up the family, and the family is a potent force in all this and can totally sabotage it and blow it to pieces. I'm actually struck by something else, which is how many of our patients are flying solo. How many don't have families, don't have even good friends, and who have come to this point in their lives where they are sort of chugging along, and we have this casting call where they're welcome to bring in anyone who's important to them into that room. And I would, it is surprising to me how few family members we've had on in there. One of the neat things about our particular study has been that we decided to make it as real as possible, and that brings up another issue, which is that these often elderly patients, the group we took, of course, were the folk who were more severely ill, are also, as you might imagine, the ones who are more likely to be cognitively impaired. So we're talking about a rather complex conversation with somebody who's cognitively impaired. We're also talking about, and this is right up your alley, your old alley, people who may be relying on other people to be their proxies, or a proxy may have been instituted that the dialysis clinic is now routinely turning to somebody else to make the decisions. And so we've sort of welcomed all that, and we're gathering data whether or not somebody is able to meaningfully make these decisions, and we're pulling in the people who are the surrogates and proxies to help out. Yeah, I mentioned that there are a couple of different prognostic indicators. These are things that are online. This is one that is based on what Mike and I did in an NIH study before this one. I don't have empirical data for you about this particular study. This, by the way, is some of the treatments if we're not giving dialysis, but these are still things that we can do that can minimize suffering on patients' parts. These are the sort of things that you asked Mike Germain about, not me. This is another one of the studies that PCORI, that's what the Patient-Centered Outcomes Research Institute calls itself. But like I said, there's about 5 different studies among renal patients they're doing. This is one of them, which is they're identifying depressed renal patients, and they're doing a trial between sertraline and cognitive behavioral therapy. This is sort of what we've been doing. This is just one of the data reports on our study. And one of the things I wanted to point out was there was a reason why I went looking for New Mexico and its 8 dialysis clinics, and that's a demographic reason. Does anybody sort of know why I wanted New Mexico from the demographic standpoint? No, the answer is Native Americans, or what you call natives or firstborn. Southwest taps into, first of all, it turns out, I didn't know this, but New Mexico is the poorest state in the United States. desperately poor population, and a part of why it's as poor as it is that there's a substantial Native American population that they are treating. Also, we have a fair number of Hispanics among our patients in Massachusetts. Most of them are from Puerto Rico originally, whereas you have more of the Mexican, Latin American coming up, forming them. So I was interested, I still am interested. We'll see what we are able to do with the data to see what happens when you study the different cultural, ethnic groups that we have. Some of the outcomes I can only tell you in sort of global terms. I will tell you that the absolute least enthusiastic social worker that we had going into this has become totally excited by the experience and told me about 2 of her patients, one of whom had been steadfastly refusing to get a prosthesis after an amputation until they started the intervention, had the conversation. Suddenly the patient is interested and has been fitted for a prosthesis. Second of her patients had been talking forever about wanting to go visit a family member in California. Yak, 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 but no action until the intervention is held, and suddenly is actually makes reservations, and arrangements are made with a dialysis clinic to take care of the patient. A lot of our social workers, as I would have expected, were pretty excited to be able to do this sort of thing, in contrast to what they mainly are asked to do, which is to arrange for the van to come and pick people up and to deal with a lot of paperwork problems that we've encountered. Our participation rate is nowhere near what I have seen in other studies with dialysis patients that Mike Germain and I have done. And so we've been scratching our heads about to try to make sense of it. You know, is it the patient exhaustion? I mean, we are choosing the sickest of the patients. Are these families just totally fatigued by caring for them? Is this, and these are all true, the fact that it's a taboo subject, this conversation that we are having with people, is that it? Certainly something I was less aware of in earlier studies, and I think this just may be trending, is this tremendous dialysis staff turnover among the 16 clinics that we're looking at. We have nephrologists who are coming and going. We have a lot of social workers who are coming and going, which means that for us, we have to train the new ones as they come in, techs and so on. A lot of movement among staff. Then there's the issue of the fact that everybody's overworked. I mean, I said the nephrologists are the hardest working people, but all the members of that team are incredibly hardworking, and we are asking them to do something more, something yet additional. Then there's the nature of the people themselves. There's some folk who, you know, welcome conversations like this, and there are other folk who want to go back to the chemistry set and, you know, count the numbers and play the experiments. And can you turn one into the, you know, can you work with the second person in an effective way? One of the things I didn't talk about that we've done in our study, and most every one of the PCORI studies has encouraged this, I did say that we have patients that are now sort of sitting around the table as members of the full-fledged members of the team. So we set up a patient advisory board, which consisted of a number of patients who were selected from different clinics, and we have 2 of these actually, one board of about 8 or 9 in Massachusetts, another one in New Mexico. What we found was it's a great idea, you know, the concept of involving patients as researchers to help do this stuff is a great idea on the face of it, but when you drill down and actually try to do it, say you have your first conference call, you suddenly discover that ordinary people, the people who are getting dialysis or the family members, they don't know from conference calls. They've never done them before. And so we thought we prepped the Massachusetts people well for it, but first one we had, 2 out of the 7 actually got on. And it took us forever to both prep them and come up with a day and time for it. And what we learned was that you have to work with people individually. You gotta bring them up to snuff. You gotta explain how to do it, just the mechanics of it. You gotta explain the protocol of what happens when you're on a conference line. Do you have to talk? Can you listen? How is this actually done? A lot of hand-holding for something as basic as that, let alone the idea of we're turning to complete laymen to help us with some research. Email, computers, maybe your patients, not a lot of our patients. Bizarre thing. I wanted to pay them out of this grant, it's a big grant, wanted to pay them, with what I thought was a well-deserved amount of money for what I was going to be asking from them. Turned out that, particularly in New Mexico, for people to continue getting the government support that they do, if you give them over $699 of outside income, they lose their government support. So, forget about the couple grand that I wanted to pay people. They're now getting $698 or something because, that's what we had to, that was one of the realities that we had to learn about. We wanted our patient advisory board to reflect what this study is, and so we went looking for folk who were sick, sicker among, and family members. What we found was that, surprise, surprise, a number of them have died and had to be replaced. A number of them have been too sick to consistently participate. A number of the family members are still, are totally exhausted by the care that they're providing. So great ideas, but you drill down and actually try it, and there are problems that you encounter. It's, I think, still the positive piece of it outweighs the negative, but there really are these negatives to take into account. What have we done to sort of deal with such things? We've invested a lot more of our staff time. We have very good directors in each of the 2 boards, patient boards, who are spending a lot of time working with the folk to keep them going. For instance, we give people a choice between coming to meetings, which most do not want to do, and having the conference calls, and we do our damnedest to try to come up with some middle ground. Compensation fee was altered to individual needs. We've needed to obviously recruit new people to take the place of the folk who have vacated the seat. All right, so that's that research that we're doing, and I'll be in a better position in a year from now to tell you sort of how it all turns out, what worked, what didn't work. What I do want to speak to now are a couple of things that I do think we have tried out before and can work, and these are things that I think when you hear about them, you will scratch your head and say, of course, they should be part and parcel of dialysis care. It's obvious why I would think that they work. The first of these is when patients die who are getting dialysis. I don't know about your clinics, and I'd be interested in hearing, but in most of the clinics that I've been involved with, nobody talks about it. There's no formal recognition of it. If I'm a patient, I may have had this person on my right on the couch who's been getting dialysis with me for the last 6 years, and one day I come and nobody's in that couch anymore. And I may or may not hear directly. I'll hear ultimately, but there's certainly nothing formal that takes place. I've found some clinics that had some means of recognizing and speaking to when people died, when patients died. One of the things that was done is local newspapers that would have obituaries, the staff would go out of their way to clip the obituary about that individual and would post it, be it on the board outside in the waiting room or inside in the nursing station. But there it would be, removing any question as far as anybody had, who that person was, why they're not coming for dialysis anymore. There could be something as simple as a notice that appears on the nursing station saying, you know, we regret to tell you that Mrs. Betsy Smith died at home. We're happy to tell you she received hospice services. You know, something of that nature, again, so that it's out there, it's not a forbidden topic, people can talk about it. And if you're worried, as I don't understand the worry myself, but a lot of people are so concerned about confidentiality, then even something that's sort of semi-anonymous, such as up on the nursing station when a patient dies, up goes a particular flower vase with some flowers in it. And you know, people know that this is in honor of Betsy Smith. They can speak among themselves, but anytime they come in and they see that up there, they know that one of theirs has died. Hospices have, almost every hospice has an annual service of remembrance or memorial service. I thought that would be a neat idea to do for dialysis clinics. And in one of our projects, Mike Germain and I kind of came up with a means of doing it. We worked particularly with a social worker, with all the staff, but there was a social worker who was especially keen on it. We created a memorial service for all the patients who had died in the previous year. I got to tell you, I was shocked by the program, just how many names were on it. I mean, there's an incredible, until you sort of see it. And all the families were invited to come on in, the way they are in any hospice that does a service like this. Active patients were told that such a thing was going on. They were encouraged to come if they would like, with their families. For staff, the staff and the patients both took part in what were very multicultural ceremonies in which there were prayers from different religions, there was poetry reading, there were chants, there was music, there was a candle lighting ceremony as each name of the person who had died was said, a bell was rung and a candle was lit until the front of the room was ablaze with lit candles. People's families, sometimes a dozen or more people were sitting together. People laughed, people cried. Afterwards, there was a little, dessert type of thing. And there was a chance in which patients and staff, let me put it differently, families and staff were able to connect, sometimes fill in the missing pieces. Staff did not know how a particular person died and they heard about it for the first time. Patients' families had the opportunity to thank staff members who had taken care of their loved ones, in some cases for decades, but had another opportunity to face-to-face thank them. Incredibly moving experience. And it gave the same message as these other things, which is that death is a part of life, and especially part of our lives when we're dealing with people who've had organ failure. Having this conversation start before somebody is stage 4 or 5, and obviously that makes a tremendous amount of sense if we think about conservative management as being an option that we ought to start offering to patients, then yeah, we got to acknowledge with them right from the start that proceeding with the full gun treatment may not make sense for them and should be dictated by what their goals are, what their expectations are, what the realities are. As we see it, it should be all part of this process. I wrote a book called No Good Deed. So a little not so tongue-in-cheek kind of reference to the situation that I kind of uncovered. I had been doing research into dialysis discontinuation for a number of years, trying to make some sense of who are these people, how do they make their decisions, once they do, what kind of quality of dying do they have, what kind of things might be done in terms of palliative care to help them, and so on. And all this I kind of did from the perspective of, for me, it had just sort of clicked with my first patient that, you know, this should be people's option, that there should be a point in which they or their families say enough. This made sense to me. So, and in the course of it, I'd met, you know, and heard some incredibly amazing stories around dialysis discontinuation, and often involving nurses who seemed to be able to face this, renal nurses who were able to face this well before the family was able to. And we had, you know, for instance, I wrote about a wedding that we had on our renal unit of a woman who was, you know, clearly in the end stages and dying, and who wanted to be present when her daughter got married. And it became evident to the nurses that she wasn't going to last for that wedding, which was set, you know, 6 months or something later. And so they got the daughter and the fiance, and they had a wedding in the hospital. And the dialysis was stopped, and the woman died a couple of days later. Quite moving experience for everyone who was involved. And that was one of a number of such stories that, or experiences that I've had. Somewhere along the line, I decided, hell, I've never actually sat down with the senior nurses and heard, you know, their perspective on things. And so I started to do that. I started to interview them. And one of them tells me this horrible story. I mean, not a happy, good death, extremely everything's great story, but rather a story in which we stopped dialysis for a woman, perfectly reasonable thing. She'd kind of just run her course, and it was time to stop, and she was okay about it, and her family was okay about it. She stayed in the hospital during the few days that it took, during which time she died. Everyone felt okay about how it went, with at least one exception. And the one exception was a nurse's aide. Nurse's aide was not okay about what happened. She was not okay about that the dialysis was stopped, and she had her own suspicions that maybe too much morphine was given to this patient. And so she went to the district attorney and accused two of her nursing colleagues of having murdered the patient. And I was floored when I heard this. The district attorney had taken it very seriously, had launched a full-fledged murder investigation. Everybody had been put on leave while it worked out over the course of a bunch of months. I will not tell you what the outcome was. You have to go read the book. But I will tell you that in investigating the book and trying to make sense of how this could happen, I found that there were a number of cases around the US at least, in which nurses or physicians were accused of, well, they felt they were doing palliative care for patients, and family members or staff felt otherwise, and they either got hauled in front of ethics boards or they had criminal proceedings begin against them. At least one poor, unfortunate physician ended up in prison for a period of time, and so on. And so this is kind of what I tried to lay out in the book. And really what I had fun with this book, by the way. You know, you write a book for the public, and then you get to go on tour, and you get to, you know, go to bookstores and read excerpts, and it's fun. I had a good time with it. But what I found, they're really, you know, we're sitting here. I'm talking to you with the assumption that everybody's on the same page about this. But not everybody is on the same page about this. There are a lot of folk, and they may be in the room, and you're welcome to speak up, who look askance at really palliative medicine, at any of the death-hastening decisions that we make, and who it's just, you know, unacceptable. It doesn't jive with who they are. This can be because of a religious belief. This can be because of the country they come from and the society that they have grown up in and how people feel about such matters. This can be because they are disabled and they fear that such things are going to be used to, in fact, kill them or other disabled people, or take away things that they have fought hard to get. Lots of different reasons go into it, but there are a lot of folk, and they take this very seriously, and they're prepared to point fingers, and they're prepared to write laws, and they're prepared to fight any attempt to do something like this. So when we talk about integrating palliative care into the treatment of nephrology, we got to be aware of this piece too. I mean, you guys are in the midst of a city that is incredibly multicultural, and I'm sure you have tons of stories that will sort of, you know, reflect this. But, you know, you as a staff person, socioeconomically different from many of your patients, and again, your beliefs, where you come from, may also be radically different. And therefore, I mean, I don't pose this as a problem. I pose this as a challenge. I pose this as, this is something that you need to be aware of, and you need to always avoid having the assumption that you're on the same page. You need to kind of work from the patient-centered part. You got to work from where the patient's at, what their goals are, what their beliefs are. So I would pretty much end on that and take some questions. And again, if you want some nice references and such, send an email to Mike Germain.